Okay, so again, this is one in a series of, I hope, are many, and this is really to give you guys an overview of where disparities stand in cancer broadly. And again, for those of you who don't know, I am a board certified hematologist, board certified medical oncologist, and I work at Stanford School of Medicine and Stanford Healthcare. So first, let's define healthcare disparities. The Department of Health and Human Services define a disparity as a difference in health outcome that's closely linked with social, economic, and environmental disadvantage, and are often driven by the social conditions in which individuals live, learn, work, and play. Keep those words in mind. The Minority Health and Health Disparities Research Act defines a disparity as, or a population in which there are disparities, as a population is a health disparity population if there is a significant disparity in the overall rate of disease incidence, prevalence, morbidity, mortality, or survival rates in the population as compared to others. Now, the National Cancer Institute, you guys can see here, has a very similar definition that I won't read, that you guys can see, but keep in mind that the same measures, the same themes seem to keep popping up. And when we talk about health equity, we're really talking about creating a situation in which we can enable everybody to receive the same kind of care in a population. That's not equivalent care where everybody is given the exact same thing. In health equity, we meet people where their areas of challenge are and provide extra services so everybody ultimately can get the same kind of care down the road. So I want to tell you about one of my most striking cases as an oncologist. This happened in the Bay Area. This was not at Stanford or in the East Bay, but this is a lovely 47-year-old African-American female. This case is old. It's several years away from this right now, but it reminds me of what we often see in medicine. So 47-year-old African-American female presented to the ER after fainting, unprovoked fainting while doing her chores. She had been eating and drinking well, but had been reporting increased fatigue and some recently started easy bruising on her arms. No abnormal bleeding. She reported some more pain in her center and lower back. No recent infections or trauma or anything out of the blue. Her blood pressure was noted to be low in the ER, but not in the area that we call shock, but it was low. Given the symptoms above, she was told that she was having symptoms related to pain and that she fainted because of her pain, and was given morphine and then given a prescription for Ativan, which is a medicine that relaxes people. It's a controlled substance, and oxycodone, and sent home. No lab work or other workup, including for the low blood pressure. So she fainted the next day again after going home and eating and drinking well. And this time she was in the emergency room, same one, asked to see a different emergency room doctor. They checked her labs and her imaging, found that she had a low white count, anemia, low platelets, and her blood work was consistent with acute myeloid leukemia, which is a medical emergency that's rapidly fatal if not treated. So it's funny because in the emergency room, we do think that having the worst symptoms makes you first. In reality, though, as we see a lot of times, this isn't the case. Her perception of the case was that she was seen as upset and frantic and complaining of pain, and that they had perceived her as a drug seeker and sent her home with pain meds. And again, this is an unusual case, but we as oncologists do see this. So cancer is a major public health threat right now. It's the second leading cause of death in the United States. We estimate that there will have been 1.9 million new cases and a little over 600,000 deaths. The most common types of cancer in men are prostate, lung, colorectal, followed by bladder, and in women, breast, lung, colorectal, followed by uterine. And you can see death rates are highest in both genders for lung, and then followed by prostate and colorectal for women, breast and colorectal, for men, breast and colorectal for women. Now, we have made a lot of progress with cancer therapy. Right now, we have 17 million cancer survivors in the US. They all have varying needs, but we anticipate this number to grow over time. This is very important from a health equity standpoint because we know children who have been diagnosed and treated for Hodgkin's disease who come from low-income communities have a 29% increased risk of lung problems following their initial treatments compared to children who come from more privileged, higher socioeconomic backgrounds. So cancer survivors have a lot of needs in the future, and health equity is an important part of that goal as well. So the ACS has a goal of decreasing cancer deaths by 40% by 2035. Just keep in mind that is their goal. So health equity is an important part of this. The total cost of cancer care last year was around, for what we can measure, $209 billion. A lot of this is taken up by cancer care in later stages. That will become relevant as we go on, but it really raises the need to identify cancers in earlier stages. So when you talk about disparities in oncology, there are many disparities across many fields. You can have racial disparities, socioeconomic disparities, geographical disparities, educational disparities, all kinds of other things. I'm just giving you guys an overview today. So when we say disparities, we talk about unequal outcomes, including higher morbidity, complications from cancer, higher mortality, unequal screening rates, differing incidence rates, different stages at diagnosis, how much of a certain cancer we have in society at one time, survivorship and quality of life afterwards, and overall the burden of cancer and other health-related communities in our healthcare system in general to primary care doctors and other providers. So disparities happen for a variety of reasons. Poverty, though, has been shown in multiple studies and probably in our anecdotal experiences to be the biggest risk factor. We know this is where the social determinants of health come in. Things such as the quality of your built environment, what kind of access you have to good food. Air pollution is a known risk factor for heart attacks and lung cancer now. Do you live in a clean area? Do you have options for exercise? Are you in a crime-ridden area where it's difficult to get out safely? But again, we know poverty is the biggest risk factor. Also, of course, some people have mental health problems that make it hard for them to stick with medical follow-ups and maintaining good health. Other barriers include other forms of financial, insurance, transportation barriers. We see a lot of this where people just can't come to the appointments. They just can't come. They don't have gas money. They just can't afford to come to the appointments or imaging or screening. Language barriers, of course, and then health literacy as to what people actually understand when you're talking to them. So that relates to limited navigation, healthcare navigation, knowledge and experience, or even just knowing what to do and this leads to unequal access to screening. You guys should know now, just an aside, routine healthcare screening should consist of breast cancer screening, lung cancer screening, colorectal cancer screening, prostate cancer screening, which is a bit controversial because of what's been told to the primary care communities, and of course, PAPs or cervical cancer screening. So remember that uninsured patients are more likely to be diagnosed at later stages of cancer. In situ means very small and controlled within the organ. Local means in the organ, but a little bit larger. Regional means advanced to the surrounding tissues, including local lymph nodes. And distant means spread to other parts of the body or metastatic. So you can see here that across the board, although the Affordable Care Act did create a little bit of a dent in this, we do see that uninsured patients are diagnosed at later stages, making it harder to treat and cure. Okay, so other reasons, differences in cancer treatment. We know certain populations, according to insurance, are offered different cancer treatments. There was a good study that came out recently that showed a glaring difference in patients who have stage 4 bladder cancer and what they were offered versus patients who had more insurance with broader coverage or higher quality insurance. So some insurance carriers will fight us for what we want to treat. They will fight us for scans, for lab work, other things like that. So remember, insurance creates some of this disparity, as do attitudes of providers. Healthcare providers see X number of patients per day. We have X amount of time. If we don't have the resources and staff around to help fight for patients, it's very difficult for patients to get what they need. Attitudes of patients. I've seen the most successful patients be the ones who are the biggest advocates for their own health. But if you don't know this, how can you advocate for yourself? So I think there really needs to be a campaign overall for improved health education in the community on various cancers. And we need to assess what attitudes patients have at baseline and really target our treatments to that. Patients who live in rural areas, as I have seen in rural Tennessee, in rural New Hampshire, Arkansas, where I've practiced, don't have the same quality of care as patients who live in wealthier or more sophisticated areas. I can say that being from rural Tennessee. The knowledge isn't there, the understanding isn't there, and a lot of times it takes a long time to get to a screening facility or elsewhere to get what you need. And of course, we see this in poor urban settings as well for the reasons that we've already discussed. There are some potential racial differences in tumor biology. We know that African American women have a higher incidence of triple negative breast cancer, and we're starting to see this some in Latina women as well. So this needs to create or lead to better screening, better access, better focus on the risk factors that can lower the risk of cancer in these populations. Now, environmental links are also a culprit, as I addressed already. Contaminated water, contaminated fish, soil with a high concentration of pesticides and other chemicals can potentially increase the risk of cancer as well. And just keep in mind that minorities and individuals of lower socioeconomic groups are more likely to be diagnosed with later stage cancers and not offered the same level of cancer treatment. And this has been shown in multiple studies in the literature. And although the cancer death rate overall in the US has fallen nearly 33% from 1991 to 2018, this is not uniformly seen for all members of society. We know that African American people have higher death rates from a variety of cancers, as I've listed here. The death rate was actually 13% higher in African American populations versus white populations for the same types of cancer in 2018. And the 5-year survival for the period I've listed here for Black people was noticeably shorter than for white people. So just some other stats to keep in mind, that 22% of African Americans, 19% of Hispanic individuals live below the federal poverty limit as of 2016 data. Compare this to 9% of white people and 10% of Asians. And you can see here, 11% of Black people, 16% of Hispanics were uninsured in this same time, compared to 6% of white people, 8% of Asians. So another area to address would be, how can we get more insurance, or at least cancer insurance coverage in these populations? Interestingly, and this has to do with all areas of society, both rural and urban, education does provide a correlation. Death rates amongst men with lesser than a high school level of education are almost 3 times greater than those of similar men who are college graduates. So now let's go over some charts. Black men have the highest cancer incidence and mortality rates compared to other racial groups in the United States. These are the rates per 100,000 people. And you can see here, just take a minute to look at incidence, which is in blue, red, which is mortality, and you can compare just overall that the death rates and the occurrence rates are higher for a group that is not equivalent in terms of numbers of our population. Black women also have higher cancer incidence rates cancer death rates, and you will see this in particular in breast cancer and some of the others that we'll discuss. So we know here white women have more cancer, but more Black women die at a higher rate. So the question is, of course, we can see this, but how do we get in and address the root causes? So now let's go to breast cancer. Black women have higher breast cancer death rates compared to all other groups. And we see this in our populations as well, in our patients. Black men have the highest incidence and mortality rates of colorectal cancer. This is a easily screened for cancer. I say easily, with some joking, as it's uncomfortable to have a colonoscopy, but they do give you medicines to make you comfortable. And we also have stool tests now that have high sensitivities. So there really is not a reason to not get colon cancer screening now. Just so you guys know, the recommendation for colon cancer screening, colorectal screening, has dropped to 45, not 50. Black women also face higher rates of colon cancer mortality and incidence. And you can see Native American women approaching this number as well. So the 4 big cancers in society, of course, are lung, bronchial, prostate, colorectal, and breast. So we're going to kind of focus on this. Look at how this breaks down by racial distribution for breast cancer. Distant, remember, a stage 4 disease that's incurable, that we spend a lot of money on at the end for very short gains. Black women have a higher percentage and higher incidence of diagnoses in later stage for breast cancer. And look how this also compares in colorectal cancer. So we're seeing the stages at diagnoses are greater, the incidence of local disease are smaller in the populations. So prostate cancer also, this is very well known in medical oncology. The death rates are much higher in Black men than other ethnic groups. And some of this has to do with screening. Some of this has to do possibly with underlying tumor biology, but there is work to be done in this area. Lung cancer incidence and mortality is highest in Black men, and this is a number that has been constant for some reason for some time in our population. Yes, this can correlate some to tobacco use, but that's not the only thing that this relates to. It's going to be interesting now that lung cancer screening programs are becoming more adopted. It's going to be interesting to see how this changes. Although lung cancer incidence and mortality rates, death rates are highest in white women, you can see that the number is closely approaching in Native American women. And remember, lung cancer is not very easily treated. The 5-year survival rate historically for stage 4 disease was around 10 to 15%, although those numbers are improving somewhat with recent therapy updates. Even stage 1 cancers have a higher risk of recurrence. And again, these patterns just seem to continue, that Black individuals are diagnosed at later stages. So cervical cancer is an infection-related cancer. We are seeing higher rates of cancer incidence and mortality in some of our infection-related cancers like cervical cancer, certain kinds of stomach cancer, liver cancer. So I want you guys to notice here the higher incidence and mortality rates in our Hispanic populations, our Native American, and in our African American populations. And of course, when we talk about cervical cancer, we're talking about biological women. Now, this is something a lot of us have seen in our practices. There are higher incidence rates of a stomach infection called H. pylori in certain parts of Southeast Asia, certain parts of Latin America, and we are seeing higher stomach cancer rates in some racial minorities as well. Stomach cancer is also very difficult to treat once it's in its advanced stages. Plus, think about the morbidity that one goes through with the cancer in the stomach. It's not particularly comfortable. And liver cancer is affected by hepatitis B, hepatitis C, alcohol use, tobacco use to a lesser degree. But you can see rates are higher in Native American populations, in African American populations, in Asian and Hispanic populations. So again, this presents an opportunity for hepatitis B vaccination campaigns, hepatitis C treatment. Hepatitis C can now be cured. We need to see who has this and focus on improved education and vaccination campaigns. So as I've already alluded to, we need to focus on programs that address the barriers that we think are there, but then we also need better research studies to see what barriers are actually there. We need community support groups like the Cancer Support Community to provide education and support and just basic knowledge to people. We need targeted programs for transportation, for health literacy. On a broader scale, we need legislation to allow improved parks and other areas where people of all communities can run and exercise. And we need good environmental standards for food and water safety that are actually enforced. Now, There is an opportunity for us to do a guided group discussion in the future, not right now, but if there is an interest, you guys can reach out to me and I can facilitate this for one of our future board meetings. If you have any other questions or want more information, there's a myriad of good information out there. I've listed some of the resources here. Thank you guys for your time and attention.